because you cannot say it's on one side go for osteocentesis and on the other side go on total hip replacement. But we have to be aware there are two main issues on that. One, which is an increasing population in Europe, are the very old patients with osteoporotic bone and this severe acetabular injuries. And the second one are the very complex injuries also in young patients, especially if also the femoral head is involved, where we know we will get a bad result and we have to think about a total hip replacement, maybe in the first place. Yeah? So there are not only two possibilities, at least there are 5 possibilities. Yeah? One is open reduction, internal fixation of the acetabulum. Second is a percutaneous screw fixation. Third is a primary total hip replacement. The fourth is a primary total hip replacement combined with some open reduction, internal fixation. And the last one is a total hip replacement after either open or percutaneous fixation of an acetabular fracture. There are certain criteria for decision making: the fracture pattern, the age, and especially in these old patients, the comorbidities. The ability of partial weight bearing in the old patient is also a big issue, and also the ability of mobilization of the patient. So I try to have a look at the literature if there are really studies which show a total hip replacement as a first procedure, if this really is a standard procedure or if somebody has good data on that. You will find, looking all through the literature, if you look close to them, it's always, most of them, the hip replacement has to be combined with some other fixations, because it's very difficult if you have an unstable situation of the acetabulum just to make a total hip replacement, because as soon as a pelvic ring is involved, the stability of the pelvic ring, you cannot really just insert a cup there and just rely on maybe on bone cement that this will give you sufficient stability on that. Though an elder study, Matter, he looked at it, and you see he has, in the old patients, the rate of anatomic reduction becomes really much poorer than it is in young patients. You see 76 in young patients and 44, 76 in young patients and 44 in the old patients. And here again, Carroll, another paper, 93 patients over the age of 55. In 58, so 69%, they orifice remaining, and around 30%, they required a total hip replacement afterwards. And there is a nice study from Mears. They also, I thought, okay, they go for primary total hip replacement, but if you look closer in it, although here in a lot of cases, again, osteocentesis was needed to get stability. You see, mean age was 69 in these patients, and a lot of them had good results to the Harris hip score. And the authors indicated that patients with displaced acetabular fractures associated with interarticular comminution, but if you look close to it, again, stability is the issue. Lynn, it's a similar work on that. Also here, Herskovici, they evaluate, but you see, these numbers are really small. 22 elderly patients. And however, because the challenge associated with the acute total hip replacement, there is a paucity of data following high energy injuries. You need a surgeon who is capable of total hip replacement, but he also has to be capable of a good surgical fixation of these acetabular defects. Otherwise, you won't really get good results. This is a German paper. They also describe using total hip replacement with an anti-protusion cage. But if you look here more close, you see 23 patients. So again, a small number. Most of them also required additional osteocentesis. So it's just not simply like that you can, in an unstable acetabulum, you can go for a simple total hip replacement as a single procedure. And we have our special aspects in old patients, so we have to be aware of the comorbidities, and not all of them we can go for big approaches and go for a good reduction. So some clinical cases, 92-year-old man, fall at home. As we see over here, we have here you see the fracture pattern. And what we're gonna try to get, at least in those cases, you see in this case, we could not really address the transverse aspect of the injury, but at least we did just to be able to mobilize the patient, we went just to fix the two columns with two cannulated screws, a very fast and easy procedure just to prevent protrusion of the femoral head. But we didn't address the transverse on this one. When we started that, we also tried it with navigation, but as I say, it's a you see the fracture over here. Sorry, the pointer doesn't work. You see the fracture over here, though we also addressed that with navigation. It's a very nice tool, but if you get a certain experience on that, I think usually you don't need the navigation. You need a very proper X-ray, but then you also can place these screws, especially with these cannulated screw systems. You can do that also without navigation and get good results. So these are after 2 years after surgery, and you see a good reduction. The joint line is really intact. Again, an 80-year-old man, a fall during shopping, and here we did in this minimal invasive way. We also addressed the transverse aspect of the injury through these screws. It's not so easy to do that. So you really have to take your time to get the correct entry point, and you can do these screws a little easier from anterior to posterior, but in some cases here we did it from dorsally, from posterior to anterior, which gives a better stability in certain cases, but is a little more demanding to place these type of screws. But again, you see good stability here, and it was possible to remobilize him immediately after surgery. So imaging is really one of the basics you have to have. And as Atul also has pointed out, you have to have good imaging. You should have a CT scan first, and the C-arm has to allow, especially the pillow of the operation theater, which is always in between. So you should have if you have a table which allows a full side, like a carbon table, and you put it so far outside that the pillar of the table is so far away that you can have an inlet and outlet view. If that works, it's nice. Otherwise, you can run into problems. Again, 70-year-old man. Here we see again and also percutaneous fixation on that one. He had a high comorbidity, but what happened here, you see, the problem in the future, it was not the acetabulum, the problem was the femoral head. So he got a total necrosis on the femoral head, and if you follow up your cases, you see many cases, the later problem is the femoral head more than the acetabulum. So he required a total hip afterwards, but this has been done half a year later on a much more controlled way. And you see it's even you can use a cementless cup here and get a good stability here, which would not have been possible in the first place when the fracture was unstable. Another one, but it doesn't work in all cases. This is a lady, I think around 65 years old, and you see high degree of comminution here. Her comorbidities have not been so high, so in this case we had to go for ilioinguinal was done in this case. I think nowadays I also would use a stopper approach. But anyway, you see this is X-rays after 5 years, and you see the joint has been preserved quite nice. And in this case, the femoral head had no problem. So this is about a predictor about the late result in those cases. Again, 82-year-old man, bicycle accident. He had a total hip on the other side. Again, quite unstable situation. And here also we went for an anterior reconstruction, being aware that there's not a really good reconstruction, but just to give so much stability which allows him to, for a certain degree of weight bearing, and mobilize the patient. And in this one, after 4 months, we went for a total hip, and after that he was really happy, had no complaints in walking again. But sometimes we have these young patients, they also have the problem. So this is a 20-year-old polytraumatized woman, chest, spine, and several long bone injuries. She also had severe pelvic injuries, so this was repaired by a posterior approach combined with this screw for the transverse aspect of the injury. And here again, the problem, which turned out later, was the femoral head. So she had nearly no more movement. So even in a very, it was 22 years now, we had to think about arthroplasty. So what I like to do in these cases, I try to use this femoral neck prosthesis, which just gives a very good stability on one side. And she was an Asian woman, so she was very small. So I had to go to very small implant here. But anyway, you can use that. So this was the shortest one available. It's even a little long here, but it worked nicely. So with that, hopefully, this implants can stay there for, hopefully, for many, many years. And she's very happy now with to get that. So in conclusion, if the pelvic ring is unstable, a primary total hip replacement without additional fixation usually is of questionable stability. A total hip after fracture healing is much safer and easier, and the femoral head injury in many of the studies is underestimated. So our philosophy is a minimal invasive procedure first to allow remobilization and prevent protrusion of the femoral head, and if needed, the total hip later. Thank you very much.